causes surgery, prevention. Most important is prevention, because I believe in that we can prevent during surgery, and if it occurs, the management. And this is the most common complication after surgical treatment of liver cystic echinococcus. Why it's important? Because it causes a lack of prolonged biliary fistula. If it persists, it causes cavity infections. It requires some interventions like ERCP and sometimes repeated surgeries, and it causes a prolonged hospital stay and increased cost of the care. And what's the types of cystobiliary communications? As Hassan mentioned about, most of them, 95% occult, invisible, and 5% frank. It causes a jaundice and cholangitis. And if we do a drainage via surgical or percutaneous technique, it becomes occult and clear. And this question is very difficult. What's the incidence of cystobiliary communication? It depends your measurement methods. If you do a histological examination, it's 100%. If you accept only persistent biliary fistula, it's 7 to 8%. And if you check all the drains from the abdomen for bile content, it's almost 20 or 25%. And we do routinely tests for bile leakage tests. Almost half of the patients has a cystobiliary communication. And what affects, what are the risk factors for cystobiliary communication? We couldn't find any relationship with the patient's age or recurrent primary cysts, or according to the anatomical size, right and left liver lobe, we couldn't find any difference for the cystobiliary communication. But we found different parameters such as expected. The diameter of the cyst is an important factor, but if it increases, the risk is increasing. And cyst stage, multivesicular, and Leonard said that if the stage increasing, the cyst risk of biliary fistula increases. The cyst content, if you remove the cyst content, if there is a bile staining, of course there will be an increased risk. And the cyst number, every cyst has its own risk factor. If you have 2 cysts, it doubles. If you have 3 cysts, it triple. And the cyst location, not right and left, the location near to the hilum of the liver, you can find more cyst-related, bile-related complications. In our experience, in caudate lobe, segment 1 cyst, 100% cystobiliary communication. So, if we know the risk factors, so there are lots of studies. Also, we did such studies. We try to find out the high-risk groups and low-risk groups to manage, to do some extra things. But now, I think that it's nonsense. So, if we can find the high-risk group and if we do some extra intervention, it's okay. But even in the low-risk group, you can face with a frank bile leakage from the drain after surgery. So now we say that a preventive intervention should be not a selected case. In all cases, we have to do it. So another topic, maybe we can do a radical surgery to avoid the complications. But this is a parasitic disease. This is not a cancer. So if we try to remove all of them, it's a disaster, I think. Because in a huge 10 centimeter, 12 centimeter cyst has a lots of neighborhood to do vena cava, right hepatic vein, portal vein, and as my friends say that one case enough for these cases. If there is a mortality because of these venous or arterial complications, this is enough. This is a benign disease, not a cancer. So also you cannot do all cases because of the position, and this is a very poor case. the patient has two cysts in the middle of the here and in the left lobe. And this patient was operated in another center, and after this complication, a disaster, moved to other center for liver transplantation. And in this case, the background of the venous drainage of the liver, the right hepatic vein, the right side is compressed, it's not working. And the middle hepatic vein in the middle compensated. And the left hepatic vein is working. There are also 3 hepatic veins, and one is not working. The other one, 2 are compensating. And in this case, the surgeon, for radical surgery, removed the left lobe and evacuate the central cyst and obliterate with the sutures, we call it capitonage or introflexion, to reduce the cavity. And the result, acute Budd-Chiari syndrome. There is no outflow, venous outflow. And this patient required emergency liver transplantation because of a parasitic disease. Okay. Radical surgery, and also for laparoscopic surgery. I think these cases are suitable for radical surgery and laparoscopic surgery. Highly selective, not selective, highly selective patients. And in our point, the conservative surgery should be the mainstay of the Hacı liver surgery. But as I said before, there are 2 problems in the early period, complex prior bile problems and the recurrence. To decrease the bile problems, we have to, do something. And what can we do? We can decrease the pressure of the bile duct. There are lots of studies for this. You can put a T-tube, prophylactic T-tube. You can do a preoperative prophylactic ERCP in the high-risk group. You can do a cystic duct drainage to decrease it. But none of them have a proven effect. Of course they decrease, but it's not zero. And another topic, you can fill the cavity with a tampon, an omentum. Yes, it can decrease. Omentopexy, omentoplasty, how do you call it? It's not important. Can decrease the cystobiliary communication. These 2 interventions, decreasing the bile duct pressure and filling the cavity, can decrease the problems, these bile duct problems. But actually, the main problem is not decreasing the bile duct or filling the cavity. The main problem is a connection between the cavity and bile duct. So we try to focus on this main problem, not the secondary points, not bile duct pressure, not cavity. So if we avoid the connection, if we disconnect it, so it will work. We believe in this. But the problem is, this connection is not visible in all cases. You clean the cavity, you wait and wait, put a gauze and wait some more, and press the gallbladder or something else. And sometimes we can see it, but not in all these cases. Sometimes we evacuate a clear, without any bile staining cavity and put a drain, and 2 days later it's draining 100 milliliter bile staining drainage. So it's not safe, it's not good. So in order to find out these invisible cystobiliary communications, we started to do an active test, a bile leakage test. And for liver surgery, you know, here, if you do a Pringle maneuver, so you occlude the distal part, and if you place a catheter, a very tiny catheter to the common bile duct, and if you fill the intrahepatic bile duct under a pressure, most of these invisible orifices become visible. I want to show you here a video. Would you mind to start the video? Okay. It's a very short one. And we place the catheter. It's an IV cannula every time, right? And we did a Pringle maneuver. We occluded the distal part, and we tried to fill the intrahepatic bile ducts with a normal saline. All these invisible bile orifices becomes visible, and we suture it by one. Okay. Does it work? Yes, it works. We published it several years ago, maybe 10 years ago, from it's a Brazilian journal. And the results, if you do not test, we see only 13%. And if we do, almost half of the cyst has a cystobiliary communication. So that means that if we only see it without test, only 1/3 of the cystobiliary communications are visible. We miss 2/3 of them. We miss them. And biliary complications, oral complications decrease dramatically, significantly. Drain removal times, of course, decreased. And hospital stay decreased. And the most important for us, the ERCP requirement was zero. I do not say that biliary complication is zero. The 8%, 9%, almost 9%, we have still drainage, but all self-limited. No persistent biliary drainage, and no requirement for ERCP. And long-term biliary problems, none, both groups. So that means that we have to do all these tests to every patient. Without putting a catheter directly to the common bile duct, does it work to use a transcystic access to cystic duct? We tried this. Of course, it can be asked from the other surgeons, but we tried it. But the junction with cystic duct and the common bile duct sometimes very low behind pancreas. So we cannot do a Pringle maneuver. Sometimes you do a Pringle maneuver and you try to flush the saline, it's not working, it's blocked. So we're still going on direct puncture to the common bile duct, and after removing the catheter, we usually suture it with the absorbable, very tiny 5-0 polydioxazine or something, Vicryl or something else. Is it cholecystectomy always necessary after this procedure? It's not necessary, but a cholecystectomy can be done after high-density liver surgery, because if the patient has a gallbladder problem after high-density liver surgery, it will be very complicated. Particularly if you use a omentoplasty or something else. The gallbladder will be behind the omentum is also. If ERCP requires, after these tests, hopefully we don't need having ERCP requirement. But in the past, in our practice, we always waited at least 10 days, because most of these biliary leakage, 2/3 of self-limited. During conservative high-density liver surgery, identification of biliary orifices with routine bile leakage tests and suturing the cystobiliary communications significantly reduce the post-operative biliary complications. Thank you for your attention.